Hi. Uh, Good morning, everyone. I'm Hashim Ali Khan. I work in the Seer Foundation Hospital back in the extreme northern areas of Pakistan. So today we will be talking about unveiling the complex systemic disorders in optometric practice, and thus we can save the life of the patients and improve their quality of life. She was a 23 years old female presented to my office for a routine eye exam. Her past ocular histories were remarkable for an exudative retinal detachment 2 years back, and she was treated with multiple intravitreal anti-VEGF injections and followed by cryotherapy. But unfortunately, the globe had shrunken and she lost her vision and perhaps the cosmesis of that eye. So after that, no definitive diagnosis were offered for the cause of the retinal detachment, and except for one document which indicated Coats disease. So she had a history of hypertension, which was suboptimally controlled with oral atenolol, 50 mg twice daily. So she was seen by an ophthalmologist just a couple weeks before she presented to my office. And she was a monocular patient, and there was no perception of light in the right eye, and it was 20/20 in the left, and confrontation visual were full in the left eye, and motility were full for both eyes, and color vision was normal in the left eye. So the intraocular pressure in the right eye was not measurable because of the corneal disfigurement and the scarring, but it was the globe was very soft. And the IOP in the left eye was 20 millimeters. On examination, there was right inophthalmos with corneal scarring and thesis bulbi. And the left anterior segment was unremarkable. On dilated fundus examination, on slit lamp biomicroscopy, her posterior pulse and much to the equator was unremarkable, but I decided to perform the binocular indirect ophthalmoscopy. So why binocular indirect ophthalmoscopy in this case, despite having a normal view of the fundus in our patient? So as this patient was a monocular patient, she already had lost one eye, and so during that slit lamp biomicroscopy, fundus biomicroscopy, I saw an unusual tortuosity of superior vasculature towards the periphery. So what bio revealed was, you can see from over here in this video and you can see that when following the course of these vessels, we can see one lesion, elevated lesion over here, and the second lesion being supplied by those dilated and tortuous vasculature. So now over here, we can see the fluorescein angiogram for that eye, and this is a poll question. So you can just quickly go for the most likely diagnosis through poll. So you can select the most likely diagnosis for this fluorescein angiogram and clinical picture of this patient.
And there's results, Dr. Khan.
All right, but I can't see the results. I don't know. All right, so most of the attendees just believe it to be a retinal capillary hemangioblastoma, and the other majority believes that it is a retinal arterial macroaneurysm. Both are quite excellent differentials. This is just have a look on another image of this patient, and you can see over here. So what we see is two elevated lesions, and two elevated lesions being supplied by dilated and tortuous feeder vasculature. So, and it could be a vasoproliferative tumor. It can be the retinal arterial macroaneurysm and arteriovenous malformation and cavernous hemangioma and retinal capillary hemangioma. So the vasoproliferative tumor usually will be in extreme periphery, would be a yellow lesion, and won't have any feeder vasculature. And similarly, the retinal arterial macroaneurysm will be located on an arteriole, won't have a draining vein, unlike our patient. So there will be no any pair of the vasculature feeding or draining the tumor, the lesion actually. And the other one, arteriovenous malformation, we can see the dilated and unusual vascular tortuosity, dilated vessels, but those vessels do not end at an intervening tumor. So in case of the cavernous hemangiomas, there will be a cluster of small vascular dilatations around a central vein, but there won't be any prominent feeder vessels. And so the retinal capillary hemangiomas, in most of the people selected, and it was the appropriate differential for our case. It will be around elevated and orange tumor, being red to orange, being supplied by a pair of dilated feeder, tortuous feeder vessels, a vein and artery. Here you can see I've just summarized all the major important things that how to differentiate between each of these tumors. The vasoproliferative tumor will be in the peripheral retina, a pale globular mass, and there won't be any feeder vessels, and there will be marked exudation. Although we can see the exudation in retinal capillary hemangioma, for that reason, I have just mentioned the Coats disease at the bottom, as our patient already was diagnosed with the Coats disease in the other eye, which was lost after the treatment, which had shrunken. So again, the retinal arterial macroaneurysm will be a small and red lesion, mostly on the posterior pole and on the course of an arteriole. And there won't be any feeder vasculature except for the arteriole, which is associated with that. And in the Coats disease, we won't see any defined retinal lesion. We only see the areas of retinal telangiectasia associated with marked exudation, and mostly it is seen in the mid-periphery and posterior pole, not in the extreme periphery like in our case. So now we have discovered retinal capillary hemangioma. So what we are going to do in next step. So once it's established that it is a retinal capillary hemangioma, we would be looking for the associations of that retinal capillary hemangioma. Some cases are sporadic and without any association, but the most important association of retinal capillary hemangiomas is von Hippel Lindau syndrome. It is multi-system, multi-organ neoplastic disorder, inherited hereditary disorder, and if not diagnosed in time and if not managed properly, can be fatal to patient in some cases and cause many complications. So, so when to suspect the von Hippel Lindau syndrome? The sporadic cases will be associated with a solitary unilateral tumor in older ages, mostly like the tumors in von Hippel Lindau syndrome are supposed to occur at younger age. And so in cases of bilateral involvement with RCH at an early age and multiple lesions and bilateral lesions, we would suspect the von Hippel Lindau syndrome. So our patient, the von Hippel Lindau syndrome has multiple associated with multiple tumors. The most important are retinal and CNS hemangioblastomas, and there will be clear renal cell carcinomas, the pheochromocytomas, and pancreatic islet cell tumors, and other visceral cysts. And the VHL is a rare disease caused by defects in VHL tumor suppressor gene, von Hippel Lindau tumor suppressor gene, which is mapped to the shorter arm of chromosome 3. The VHL protein regulates the hypoxia-inducible factor in an oxygen-dependent manner. So we believe that VHL protein has a key role in the oxygen sensing function of the cell. How your VHL protein are the products of your VHL gene works. So the VHL gene is involved in ubiquitination and degradation of hypoxia-inducible factor 1 alpha and HIF2 alpha. And in under normoxic conditions, in the states of normal oxygen supply, and this is not only involved, this VHL protein and HIF are not only involved in the pathogenesis of just von Hippel Lindau syndrome, but other retinal vascular disorders as well. So under normoxia, it serves as a substrate recognition subunit of the ubiquitin ligase complex, and then the hypoxia-inducible factor is hydroxylated and it binds to the von Hippel Lindau syndrome, von Hippel Lindau protein, and is degraded rapidly through proteasomal degradation. And in hypoxic condition, you can see from the figure that in under hypoxic conditions, our VHL protein fails to bind to the hypoxia-inducible factor, and then hypoxia-inducible factor starts facilitating the transcription of downstream genes. And so likewise, the VHL, a defective VHL protein can't bind to the hypoxia-inducible factor. From the figure, we can see that there are no binding sites for hypoxia-inducible factor on the VHL protein. So again, it fails to bind to the hypoxia-inducible factor. Hypoxia-inducible factor fails to bind to the VHL protein, and thus it results in the transcription of hypoxia-inducible genes. These genes include vascular endothelial growth factor and transforming growth factor alpha, and then we have the platelet-derived growth factor, and then we have the erythropoietin and its receptor, and we have the transforming growth factor alpha. Here I have just summarized the important tumors associated with the von Hippel Lindau syndrome, and their clinical findings associated, and the investigations which are helpful in diagnosing each of these tumors. So the most important are from the optometric perspective. The most important one is the retinal capillary hemangioma. It will be associated with, not always, but it is associated with visual disturbances and peripheral retinal tumors. So we can, and sometimes we will talk about the retinal capillary hemangioma in details later on. So we can go for the wide field fundus imaging and fundus fluorescein angiography to diagnose that RCH. Then there will be central nervous system hemangioblastomas, 75% of which are cerebellar in nature, and the patient will be having headache, nausea, vomiting, ataxia, and other things. And so for that thing, we need to go for the magnetic resonance imaging, which should be the gadolinium enhanced. And for the clear renal cell carcinoma and cysts, the cyst will be usually asymptomatic, and RCC will be associated with the hematuria and lower back pain. So for that, we need to go for the abdominal ultrasound and computed tomography of the abdomen. Then the other most important associated tumor is pheochromocytoma, which spells with the 4 characteristics: hypertension, palpitations, headache, and diaphoresis. So for that thing, again, where we need to go for the plasma metanephrine testing through 24-hour urinary collection for catecholamines and metanephrines, and also can be diagnosed on the ultrasonography and CT scan. So the other things, the pancreatic cysts and tumors and endolymphatic sac tumors are usually diagnosed with the CT or MRI or the ultrasonography. So now we will be talking about the diagnostic criteria. So in patients with negative family history, just back to our patient, the patient did not have a known family history. So 2 or more retinal capillary hemangiomas, or 2 or more CNS hemangioblastomas, or a CNS or retinal hemangioblastoma and a visceral tumor is necessary to meet the diagnostic criteria for diagnosing the von Hippel Lindau syndrome. In patients with the positive family history, there may be 1 or more retinal or CNS hemangioblastoma, and is sufficient to satisfy the diagnostic criteria. Or in settings of a positive family history, even a single visceral tumor may be sufficient to diagnose the patient with von Hippel Lindau syndrome. So these visceral lesions include the renal cysts, renal cell carcinomas, the pheochromocytomas, the pancreatic cysts, and epididymal cystadenomas, endolymphatic sac tumors, and a few others as well. So in our patient, there was no family history of VHL. Perhaps I won't call it a negative family history because the patient in our region, the patient had a poorer access to healthcare facilities, and the patients oftentimes have limited educational backgrounds, and so maybe many patients might have been undiagnosed. So our patient had 2 retinal capillary hemangiomas, and there was she also had hypertension. And for the right thesis bulbi, I believe that it would be probably it was because of a complication of retinal capillary hemangioma, actually, not because of the presumed diagnosis of the Coats disease. So our patient had then, and in having the patient had hypertension, which was suboptimally controlled, but no physician work was done before. So it raised our suspicion for a renal lesion. So what we began with investigating for the VHL tumors elsewhere in the body. So we went for a gadolinium enhanced MRI of the brain and spine, which was unremarkable. Then we went for the ultrasonography of the abdomen, and which raised our suspicion for pheochromocytoma. There were 2 solid hyperechoic foci in the suprarenal region. So after just going through the results of ultrasonography, we decided to go for the computed tomography of the abdomen. And the findings were consistent with the pheochromocytoma. The patient was sent for the nephrology consult, and she underwent surgery for the pheochromocytoma. The diagnosis was further confirmed with the histopathological study of the mass removed during the surgery. And we also sent the patient for audiology assessment and otolaryngology consult, and which again was normal. And here you can see the image from the CT scan of the kidney, and you can see the radiologist has marked a lesion which they believe to be the pheochromocytoma. We will be discussing it from the optometric perspective, actually, the features of the ocular disease. So the retinal capillary hemangioma, as we discussed before, are the hallmark sign of von Hippel Lindau syndrome, and it is actually, in most cases, it is the earliest sign of the von Hippel Lindau syndrome. And most of the lesions are peripheral, and but up to 15% are either peripapillary or extrapapillary in nature. So they may appear around the optic nerve or optic disc. So according to the morphology, they can be the endophytic lesions, exophytic lesions, or sessile tumors. So the exophytic tumors grow on the surface of nerve or the retina and protrude into the vitreous cavity and are easily identifiable. And those exophytic tumors are nodular orange color lesions that grow in the outer layers of the retina and usually close to the optic nerve and can simulate chronic papilledema. While these sessile lesion growth patterns are relatively flat, gray or orange in color, and develop in the middle layers of retina. And these lesions the sessile lesions are very subtle and in appearance and may be a diagnostic challenge for the clinician. And here we can see on the right top, over here we can see the fluorescein angiogram of 3 lesions. All these are the peripheral lesions, and they are quite well defined, although the lesion over here is quite very small, but we can just see it but on the right lower corner image, this is a clinical image, although a bit washed out, but the lesion is not really that clear. So on the left side, you can see the corresponding composite full thickness OCT angiography image of this eye, and you can clearly see a lesion which is very well defined, although it is not defined on the clinical image, but it is very well defined on the OCT angiogram. So OCT angiogram can be very helpful in where the lesions are really subtle. So in very few cases, the retinal capillary hemangiomas may remain silent and stable for many years, but it has been documented in the literature actually that in a minority they may regress spontaneously, but most of the cases they progress and result in further complications in most eyes. The retinal capillary hemangioma begins leaking the fluid, and extravasation of the fluid causes the retinal exudation, results in the reduced visual acuity, and then further is complicated by tractional retinal detachment or a rhegmatogenous retinal detachment. And with further, and all this is because we have just described the genes which are just overexpressed in the VHL eyes because of the mutant copy of your VHL protein, and these vascular endothelial growth factors and transforming growth factor alpha and erythropoietin and other things. These cause the vasodilatation and tumorigenesis, and once the vasodilation and increased permeability of caused by these growth factors and inflammatory cytokines result in the exudation, and then further is complicated by the tractional retinal detachment and rhegmatogenous retinal detachment. And with continuous overexpression of these angiogenic factors, these eyes develop the neovascular glaucoma and even then end up in a painful blind eye or shrunken eye, the thesis bulbi. So now We have some severity staging of the ocular disease classification and severity staging. So there are multiple schemes. The most commonly known and actually the older classifications, which are most commonly used and widely practiced, are the Wells classification and Singelmann's classification. The Wells classification has 4 stages, and the Singelmann's classification has 5 stages. But interestingly, the stage 1 and 2 of the Singelmann's classification correspond to the stage 1 of the Wells classification. They both correspond to a formation of a lesion and angioma, the tumor, and it is just the first 2 stages of Singelmann are corresponding stage to that, the first in the Wells classification. And then in stage 2 of the Wells classification, there would be the development of hemorrhages and exudation. And then in the 3rd stage, there will be massive exudation and retinal detachment. And then the 4th stage is for the end stage complications of VHL disease or complications of that retinal capillary hemangioma. This includes the uveitis, the absolute glaucoma, and loss of the eye. And but there are some limitations which are not taken into account by these classification methods. For example, the last 2 stages of Singelmann's system correspond to the stage 3 of Wells classification, but the Singelmann's classification is not taking into account the complications and advanced ocular disease caused by VHL. So other classification methods have been attempted by several investigators. So the latest one, and the one I personally believe is the better classification system, is the scheme developed by Venkatesh and Tucker, and it is the recent one. And the method classifies the retinal capillary hemangiomas and their manifestations on the basis of their clinical activity, the depth location of the tumor, and distribution of the disease according to the retina. So there are 3 zones. And 2 major categories, and with multiple subcategories. So, and the one in their system is the anterior pole and optic disc, while the region between the zone 1, which is your vascular arcade to equator, is 2. Beyond the equator, so your zone 3. I'm just having a problem with my internet connection. So there is now there are categories of Venkatesh and Tucker classification method. So there are they either are preclinical. The stage category A is preclinical, so you will be only seeing a twin vessels, without any visible microaneurysmal changes. And category 2B, it is the clinical category in their classification method. So in the category B1 corresponds to the intraretinal aneurysmal dilatations and macroaneurysmal dilatations. And the stage 2 category 2 is the extraretinal manifest of the RCH, there will be an extraretinal hemangioma without any surface vascularization. And in the other category, there will be the lesions with surface vascularizations is classified as 2B, and with surrounding scar tissue proliferation, they are classified as 2C. So in the category 3, category 3 covers the retinal detachment, and category 4 covers the manifestations of the disease. In the category 3, there will be the retinal detachment, category 3 corresponding to the focal traction, and there will be in stage 3B, there will be extensive traction, and 3C corresponds to the total retinal detachment of any occurring due to any etiology. And the final one, the stage category 4, corresponds to the advanced manifestations of the disease. So a new vascular glaucoma, vitreous hemorrhage, and painful blind eye, and these complications of retinal hemangioblastoma are placed in the advanced category 4. So from this classification system, if any extensive retinal traction exists between the retinal vascular arcades and equator, it will be classified as zone 2, stage 3B, while zone 3 stage 2C describes a retinal capillary hemangioma with surrounding scar tissue proliferation anterior to equatorial retinal gear system. So this scheme appears to be more clinically useful, and particularly may be very helpful in deciding the treatment plan, and it's more reproducible and more useful clinically, and perhaps maybe more useful and more reproducible in research settings as well. So for the management of retinal diseases,